Hello everyone, this is Seher again for comprehensive review of periodontics. So let us see what we are going to do here. So firstly, we have the table of content. We are going to discuss about periodontium, flap grafts and surgery, gingivitis, gingival condition, periodontitis, osteotomy, plaque and calculus, SRPs, instrumentation, like the use of scalers, power-driven instruments, occlusal trauma, abscesses, points about oral hygiene instructions. Now let us see here. Now we can divide the periosurgeries into periodontal resective surgeries, minimal resective and the non-resective. So resective surgeries, we have like hard tissue, the osseous surgery like osteoplasty, ostectomy, crown lengthening, root shaping for the hard and the soft tissue. For the soft tissue only, we have the gingivectomy, gingivoplasty, and distal wedge procedure. In periodontally minimal resective surgeries like open flap debridements or Widman flap, modified Widman flap, laser assisted MWF, ENAP procedure, or the LANAP procedure. And the periodontal non-resective surgeries, we have open flap debridement, apical position flap, single flap approach, or papilla preservation flap. Okay, so now we can see the incisions in perio are divided into two groups. You have the horizontal incision and the vertical releasing incision. The horizontal incisions are divided into three types: internal bevel, crevicular, and interdental. And the internal bevel incisions are the primary incision of the first incision of perio. You can see the direction of them is internally, that is from the gingival margin towards the alveolar crest. And why it is called as bevel, we can see the surgical blade is placed at an angulation. So the internal bevel incision helps in removing the pocket lining, conserve the outer surface of gingiva, and produces a sharp thin flap margin for the adaptation to the bone tooth surface. The second incision we have is the crevicular or the sulcular incision that is given directly into the sulcus, while the internal bevel incision was 1 to 3 mm away from the gingival margin. One thing also about the internal bevel is called a scalloped incision, while the second crevicular incision is also called as the sulcular incision. And this is the third incision called as the interdental incision given by the Orban or the Kirkland knife. Okay, so now we are coming to the modified Widman flap. We know this flap is the undisplaced flap. That means you're raising the flap, doing the procedure, and then you're putting the flap into the same position. It's a full thickness flap. So modified Widman flap is mainly used in open flap debridement procedure, regenerative perio procedure like grafting, and it's a very important procedure for doing surgery on the single rooted tooth, and healing is by primary intentions. Chances of scarring are not there, and that's the reason in aesthetic zone modified Widman flap can be easily used. So this flap is for reducing the shallow pocket depth, gain access to underlying bone and root surface, and reduce the pocket depth by establishing a new attachment at the more coronal level and preserve the zone of attached gingiva. So modified Widman flap is mainly used when the pocket base is coronal to mucogingival junction. That means we have a shallow pocket and where aesthetic is important. You can see different steps in the modified Widman flap. You are giving the internal bevel incision first. As we discussed, you are giving the crevicular incision, and these horizontal incision are carried along the alveolar crest. So there are no vertical releasing incision here. And then you can see how we are using the curette to do the root planing under direct vision. Okay, so now we can discuss about the position flap, in which the flap caudal margin is advanced, lifted, but flap is not completely freed up. It is still attached at one end. So you are going to raise a flap at one position and then you are lifting the flap apically, laterally, or coronally. So these are called as displaced flap or the position flap. So the flap will be at a newer position relative to its original position that they occupied before the procedure. So there are mainly three types of position flap or displaced flap which are important. You can see the one we have is apically positioned flap, then we have the pedicle or laterally positioned flap, and then the coronally displaced flap. So pedicle flap laterally positioned, they are full thickness flap to correct depth in morphology, position and amount of attached gingiva. You're raising this full thickness flap and the free end is lifted or displaced laterally until it covers the defect. So when there's an area of narrow gingival recession, to create a wider zone of attached gingiva, wider band of gingiva, correct or prevent the recession, you can use the laterally positioned flap. You also have a double papilla flap. There's a variation of lateral position flap in which you are like a curtain. You are splitting the papilla on the mesial side, on the distal side, and you're closing it like a curtain. So it's like a double papilla flap. The second very important flap, as we know, is the apically positioned flap. It's a full thickness flap. It is considered to be the workhorse of the perio surgery. So in this flap, objective is to surgically eliminate the deep pocket by positioning of the flap apically. It's the most important flap. So this flap can be used in conjunction with the osseous surgery, as surgical access is obtained for osseous surgery by using a full thickness apically positioned flap. This flap can be used for treating moderate or deep pockets, even furcation involvement tooth, and also for the crown lengthening procedures. However, this flap should not be used in the patient for risk of root caries, because after apically displaced flap there will be more exposure of the root, and where the tooth exposure would be anesthetic. You can see more points about the contraindication and apically positioned flap that is used with or without osseous surgery. What are the indications of them here? Also on the other page we can talk about the coronally positioned flap, the new attachment procedures, and the regeneration. So coronally positioned flap is the third type of displaced flap in which you are raising the flap and then stretching it or lifting it coronally to cover the defect. And this flap is exclusively used to restore the gingival height and the zone of attached gingiva over isolated area of gingival recession. Although with the flaps, since they still maintain their blood supply, there is no necrotic slough or position flap, because position flap still carry their blood supply with them. That is not the case with your grafts, because grafts are the completely detached piece of tissue we have. Now we can see here on the other page, we can also have the discussion about the new attachment procedures, which are the reunion of the connective tissue by the formation of new cementum with inserting collagen fibers on the root surface that has been deprived of its pedial ligament. Now the regeneration procedure like grafts, GTR, definitely they come in the regeneration procedures. Okay, so on this page we can see the stages of periodontitis, starting with the stage 1, stage 2, stage 3. That will be the established stage. Stage 1 is the initial stage, stage 2 is the early stage, established, and finally the advanced stage. What are the signs and the pathogenesis of them? So, and this we can see the horizontal, the generalized bone loss, and the vertical, which is the angular bone loss. What are bulbous bone contour, reverse architecture, that you can go through it here. Okay, so now we can see the clinical attachment loss. Significance of clinical attachment loss is important in evaluating the periodontal disease compared with the probe depth measurement. And we can see here how you are measuring. So you're using your periodontal probe to measure the distance from the gingival margin to the maximum depth of the pocket. And clinical attachment loss is the distance from the fixed reference point CEJ to the maximum depth of the pocket. So you can see here 3 mm is the recession, 6 mm is the pocket. So your total attachment loss is going to be 9 mm. So you can see this picture. It's very helpful because in the exam you can have some math questions related to them. Okay, so on this slide, we can discuss about the role of endotoxins in the bone loss. So we know that the bacteria in the periodontal health are the gram-positive non-motile facultative anaerobes. They are the harmless or the helpful bacteria. But in periodontal disease, definitely your balance will shift to the gram-negative, motile, and strictly anaerobic bacteria. So these bacteria, they are producing the endotoxin that is causing the major bone loss. Now, some of the conditions in the patient that can predispose them to develop more inflammatory periodontal condition is definitely the genetic factors, pregnancy, diabetes, agranulocytosis, neutropenia, leukemia, autoimmune disorders, Down syndrome, HIV. So these are some of the common conditions. Now, the major bone loss in the endo, in the periodontal conditions, we have 4 cytokines: TNF alpha, IL-1 beta, IL-4 and PGE2. They're considered to be very important in regard to the bone loss. When you have those are the inflammatory mediators, but if there overproduction of them, these are the ones that are going to start your bone loss. So we can see this flow chart, go through it, how the periodontal pathogens are affecting the bone by creating oxidative stress, tissue damage, and decreasing the bone resistance to fight with the infection. Now the occlusal trauma, primary and secondary occlusal trauma, primary occlusion trauma like due to bruxism, due to traumatic occlusion, while secondary occlusal trauma when the occlusion is not traumatic but your perio is diseased due to, let's say, uncontrolled diabetes. So to reduce the occlusal trauma, we can do the selective grinding or occlusal equilibrium to have more acceptable centriculation contact for acceptable lateral and protrusive guidance, and so that all the forces are borne by the long axis of the tooth. We can see the signs of trauma from occlusion too that are given nicely here. Please go through it. Okay, so on this page we can see different types of toothbrushing techniques, which is very important topic of exam, where we can see the Bass method, modified Bass, the Charter, Stillman method. Mainly in the exam they ask you like which technique is most common, a technique like horizontal scrub technique, which is the most effective technique, like a modified Bass technique, which is least effective is the force technique that you usually use in children's, making like large circles. Then they can ask which technique for the orthodontic appliance patient, like a Charter technique. So you can go through the details of the technique here. Hi my dear student who are preparing for IMD ADAT or Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the DentaBest channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from DentaBest, wishes you all the best for exam and thanks again for watching.